Busy, all of us today, co-hosts. I'll be starting my talk first. My name is Sanju Sobnach. I'm currently the clinical head of transplants at WITS. And I will be talking about the transplantation criteria for HCC in Sub-Saharan Africa. And then Bilal Babat, who is currently the transplant hepatology lead at the Donald Gordon Medical Center, will give us some pearls regarding immunotherapy for HCC, particularly in Sub-Saharan Africa. So I'm going to share my slides now. Cheryl, can we see this?
Yes, we can. You can go ahead.
All right. So I think this has been a very contentious point of debate in the last IHPBA meeting, and the question that's been posed to a number of us is which criteria for liver transplantation for HCC should be applied in Sub-Saharan Africa. And many of us are, particularly from LMICs from India, from Southeast Asia, and Sub-Saharan Africa, think that we should be ditching the metro ticket concept for a Cape to Cairo journey. So let me just show you what we mean about the metro ticket. So traditionally, the metro ticket was founded on a number of transplant criteria from high-income countries. So on the left-hand side, you can see what Milan criteria means. Essentially, these are criteria to tell you whether a patient with HCC can be transplanted or not. So for Milan criteria, generally, we look at a single tumor of not more than 5 centimeters, or up to 3 tumors, none of which should be more than 3 centimeters. There should be no macroscopic vascular invasion, and there should be no extrahepatic spread. I think for the last 2 criteria, most of us would agree whichever part of the world we're from. But then again, as transplantation has evolved, some centers have gotten braver. So with San Francisco, you can see they accept larger tumor sizes. And then more recently, the Toronto criteria came out where they essentially say number of lesions don't matter as long as there's no extrahepatic spread and no macroscopic vascular invasion, and the patients show no signs of evolving cancer, but they should have histology. They should be well differentiated or moderately differentiated with an AFP less than 400. But again, as you get braver with your criteria, you can obviously see that the cost of the metro ticket goes up, which means in this case, the cost is survival. So the 5-year survival decreases with braver or more adventurous criteria, and the 10-year survival obviously goes down as well. So let's look at the metro ticket. For those of you who've been in the metro in France, you will find out that it's quite generic. The seats all look the same. And a Cape to Cairo concept would mean that it's a bigger adventure. You would start from Cape Town. You would go over Vic Falls and all the way up to Cairo, and you would use a very fancy train to do that. This is the Rovos rail that some of us will be fortunate enough to travel on in the future. And the cost of that is very expensive. So a 15-night trip from Cape Town up to Tanzania to Dar es Salaam is about $23,000 US. So the cost is high. So let's talk about HCC. This is a generic slide of mine, but I think it puts the disease into context. It is the 6th most common malignancy worldwide. 80% of all HCC cases come from Sub-Saharan Africa and Southeast Asia. If you look at HCC in Sub-Saharan Africa, it's a 2nd and 3rd leading cancer in men and women respectively. And about 40,000 people die of the disease on an annual basis. In some parts of Sub-Saharan Africa, like Mozambique, the age standardized incidence is as high as 102 per 100,000. So high-income countries versus low-income countries, patterns of disease are different. In high-income nations, they're predominantly cirrhotic. The median age is 65. MAFLD is probably the predominant etiology. And the aim when treatment is initiated is to aim for 5-year survival of 70%. In our setup, things are a bit more different. 40 to 80% of our cases are non-cirrhotic, 40% are HBV related. Our treatment responses are very poor. The median survival with sorafenib, which is commonly used in high-income countries, is only 106 days, which beckons a question whether our tumor biology is a bit different. So this is classically what we would see. This is a 40-year-old man with a 3-month history of abdominal pain, clinically a mass with a normal AFP, Hep B surface antigen positive, actively replicating at 1 million, with a MELD of 7 and a Child-Pugh A6. This was unfortunately a colleague of ours, 48-year-old gentleman from sub-Saharan Africa with a 6-month history of low abdominal pain and a big mass, high AFP, replicating actively with hepatitis B, a MELD of 13 and a Child-Pugh of B7, and was admitted to us on the Friday and passed away on the Sunday. We have looked extensively at HCC in our unit. So just to tell you, we did a systematic review looking at every single piece of outcomes data there was in sub-Saharan Africa, and we had 3,989 patients. 4% were resected, 0.2% were ablated, 0.8% were transplanted, so that's less than 1%. So in all, 5% had curative therapy, and the great majority of patients, 86%, were treated with best supportive care only. And if you look at the published data out there, this came from current center of our work at Dargol Medical Center, where the transplant rate was 31 patients were transplanted for HCC with quite superior results compared to high-income countries. So in our experience, this is a massive experience of ours. I think it's over 34-year experience of 679 patients. We look here, we transplanted only 8 patients in this massive cohort, so only 1.2%, and they survived 2,589 days. And well, I'll show you the Kaplan-Meier in the next slide. But just to show the median overall survival of a large cohort of patients of sub-Saharan Africa is 91 days. So non-cirrhotic HCC in this cohort was 42%. About 11% had portal vein tumor thrombosis, 23% had extrahepatic metastases, and 47% had multifocal disease. So this is the Kaplan-Meier in a cohort of 679 patients with an 85% follow-up from diagnosis to either death or present survival. And the arrow here is to show you the patients who underwent transplantation. Until now, our patients, essentially these patients have not died. And the rest of the data shows that our patients kind of behave almost the same as patients from high-income countries. Now, when we apply different sets of criteria to this, so on the left, if we apply Milan criteria to this cohort, we found that 6.7% of them are eligible for transplant. If we apply the UCSF criteria, it's 7.7%. And if we apply the Toronto criteria, we stay at 7.7%. We plateau at about 8% essentially. So we all know this. This is the Barcelona criteria. We all love talking about it. And it's the concept that one size does not fit all, particularly for HCCs in our setup. So let's see what our patients are essentially eligible for. So, well, at the moment, most of them should just be eligible for TACE or best supportive care. Systemic therapies, so biologics are currently not available in state. They've been recently available in Johannesburg only on the basis of a trial. And the rest of the therapies are quite difficult to administer, given that most of our patients are out of criteria upon presentation. So this was recently published in the SSA by Lindemann from the University from WashU in the US, when they've looked at different criteria for transplantation. So at the top is Milan, where overall survival at 5 years expected is 80%. And then there's a UCSF criteria, 77.8%. You can see the Dubai, which is the extended Toronto criteria, 70%, so matched at 5 years. And then with Christian Tozo up in Geneva, 60%, where they use much more aggressive criteria. So there are guidelines for this, and they're available on the ILTS website. I just want to show this again to show you that with the Toronto criteria, provided the biology is good, and the surrogate for the biology in these cases is the degree of differentiation on the histology, you can see that the survival, yes, is slightly lower, but at 5 years, you're still achieving about 50 to 60% survival in these patients. So what would it mean if we had to go with a Cape to Cairo concept? It would mean that we will have to take more risk. It would mean that we will have to look for other surrogates of biology. And it would also mean that we will have to be very careful with the selection initially, because this is going to be a costly journey. So let's look at liver transplantation for non-cirrhotic. So it's unresectable hepatocellular carcinoma in normal livers, essentially non-cirrhotic organs. And this is essentially the only paper that is out there where they have looked at 62 patients in a primary transplantation group. This is a multi-center study from Europe. And if you look at the 1-year survival, 80%, 1-year tumor-free survival, 74%, and 5-year survival at 40%. For non-cirrhotic disease, you match your survival matches HCCs, cirrhotic HCCs treated with Toronto criteria. So non-cirrhotic HCCs do appear to be much more aggressive. This is very relevant for our setup because close to half of all of our HCCs that we currently see are non-cirrhotic. So what about patients with portal vein tumor thrombosis? This is from the Medanta group up in India. Large volume center, does about 300 liver transplants, 350 liver transplants a year. And they have a downstaging protocol. So patients who have portal vein tumor thrombosis undergo SBRT and then are ablated further with TARE, radioembolization, TACE, RFA, or microwave. And then they go on, they're either on sorafenib and they get reevaluated with a PET-CT every 4 weeks from 6 to 12 weeks. After that, if they're downstage, they undergo living donor liver transplantation. And if you look at this chart, this is from the paper. They've gone on to compare 25 patients who were downstaged and 25 patients with portal vein tumor thrombosis who did not undergo radiotherapy, so no downstaging. And if you look at the survival in the patients, what they showed is that the patients who were downstage with radiotherapy, there was no significant difference in overall survival. But interestingly, what it showed is that at 5 years, you could still achieve a 5-year survival of 57% in patients with tumor thrombosis. So that's very interesting and relevant data for us. So I always say this is kind of my dictum. I think all of us should be treating biology rather than mass disease. I think the mass disease, the large tumors that we see are just a manifestation of what happens at a cellular level and tumor growth. But the biology itself still needs to be deconvoluted. We are busy attempting that. We've been at it for about 2 years, and we hope to have some more results as we go. So how do you better select patients for transplantation? I mean, I think one of the suggestions is to integrate true biology and patient data. I mean, this is our protocol. We keep on sharing this at every talk. We do genomics, metabolomics. We're doing single cell for a number of patients and exosomes. And we've already shown that patients whose tumors produce a large amount of 2-hydroxybutyrate as a breakdown product have worse survival. We recently showed that quite convincingly that in patients who undergo TACE, you can predict, this is personalized medicine in a way, you can predict outcomes. So patients who have lung metastases or gamma GT of more than 800, along with high hydroxybutyrate levels, fail their TACE. So in our unit at the moment, if you have those three, you are not given TACE. We are quite adventurous with TACE. You are given best supportive care only. The study is currently underway. There are 2 more patients that need to be recruited to complete the study. So this is single cell sequencing to study the biology at a single cell level, to study the tumor biology at a single cell level. You can do this in your theater, and you can load the Hive. We're actually teaching our clinicians how to do that at the moment. And at the end of it, you can split the tumor at a cellular level and see what genes are being expressed within these tumors. So Cape Tocara concept for liver transplantation in sub-Saharan Africa should include a few concepts. We are open to criticism with that. We believe that size does not matter here. Extrahepatic disease is an absolute exclusion at this point. Biology matters. In our hands, we figured out that multi-omic approaches will become very useful and part of our practice in the future. One must test biology of these patients. At the moment, we test the biology by offering them treatments. So TACE, sorafenib, TEA in some very selected cases, radiofrequency ablation. And if they fail that, we say the biology is not suitable, and these patients end up having essentially a natural selection pathway. I think bridging will become the essence of us treating or managing these patients for liver transplantation. That is certainly challenging a setup because TACE and TEA is not available everywhere. Biologics and immunotherapy are not easily available in state or not at all. And doing combination therapies are extremely difficult. Certainly in Johannesburg at the moment, one of the thoughts we've had is to use marginal grafts, so DCD splits, which we do a lot already, and machine perfusion in the future. And one should have very different benchmarks as what is acceptable for HCC outcome, as an HCC outcome in sub-Saharan Africa. We're not saying we should have less good outcomes than in high-income countries, but I think the expectations should match the biology of the disease. So at the end of it, I'm going to conclude by saying that Cape Tocara concept or adopting biological data as part of your criteria for liver transplantation is an expensive process. Having a big bridge and bridging a lot is probably key given the epidemiology of the disease in our setup. And certainly this is going to be a scenic journey for most of us with many challenges with regards to outcomes, probably in the beginning of it. I'm going to say that we have more questions than answers at this stage. I think that's why we have these forums. I mean, all opinions are worth listening to before we come up with an eventual set of criteria that is suitable for us. It is very difficult to follow standard criteria at the moment for liver transplantation in sub-Saharan Africa because things are obviously a bit different. The disease does behave slightly differently. Downstaging techniques are important. I just want to point out that when you start building up downsstaging or integrating downstaging techniques into your algorithms, you improve a lot of the peripheral services. So your oncologists get better at using new therapists. Your radiologists get better. Your physicians and surgeons are more keen to treat sicker patients. So there's obviously a lot of collateral improvement in ancillary services. And I'm going to say this over and over again, it's important to treat biology rather than just tumors that we see on imaging. So I'm going to finish here. I think I will take some questions before Bilal's talk, because I probably will have to leave in between. All right.
Looks like you stunned everyone, Sanju.
Bilal, welcome.
Sorry, everyone. It's a busy day here. We're transplanting a patient in a bit, and everyone's running around. Sanju, I'm not sure if there are any specific questions that anyone might have. If not, Dominic, I'm going to answer that question for you in terms of bridging and downstaging. I'll be able to answer that in my talk. So Sanju, maybe we can excuse you back to theatre.
Okay, thanks, Bilal.
Okay, I'm going to just share my slides and let's hit play. Okay, is that
yes,
yes,
we can see, yes, we can see it, Bilal.
Okay, so something that's somewhat more topical and you guys will be seeing more of is regarding immunotherapy in HCC transplantation. This is as a result of the IMbrave 050 trial that came out last year, looking at outcomes of patients with effectively neoadjuvant therapy for HCC. So just in terms of, what has already been established, and apologies for missing the first bit of Sanju's talk in case the slide was already covered, but we already know that the global burden of HCC is considerable, and it certainly does affect Sub-Saharan Africa and West Africa, as you can see, quite considerably. This is mainly due to the prevalence of viral hepatitis B, but there are other etiological factors at play. And in the West, for instance, metabolic associated steatotic liver disease is certainly becoming more and more prevalent as that pandemic evolves. So, in terms of where transplant sits, it's your real curative sort of procedure. You could argue that it even supersedes resection, as it removes the tumorigenic environment that liver cancer arose from. There are other therapies in terms of local regional therapies and almost controlling therapies that are additionally available. But in Sub-Saharan Africa, we really don't have all that much access to things such as resection or transplantation. As you can see, only 1% of patients in Sub-Saharan Africa having access to that. Ablation, a similarly poor number, somewhat better in terms of resection. The vast majority received best supportive care, which is often just really some form of analgesia, and that's really because of late presentation. Your South African transplant data, COVID acted as a double-edged sword, because it really did curtail the number of deceased donors that we received as a transplant unit. But at the same time, then it forced the progression of a living donor program, which has been growing and is opening up further opportunities for individuals to be transplanted, especially when it comes to relative marginal indications such as HCC that has been potentially downsstaged. In terms of transplant for HCC, the published data is really the one paper from Johannesburg at our unit, looking at 31 patients, the majority being HPV related. Those within UCSF criteria showed a 1-year survival of 88% and a 5-year survival of 72%, which is very well comparable to overseas standards. So, only 31 patients, and, I thought you said it was a problem. Yes, it certainly is. And this goes to show just the incidence and the mortality. Most of these patients are actually passing away before being able to access adequate therapy, and it is at the moment still just a very select group of patients that are able to access curative therapies. So let's look at a bit of that algorithm. This is the Barcelona Liver Clinic liver cancer algorithm from 2013, and as you can see, broken up into something which I think most of us can recognize. Have a look at last year's publication of that same algorithm and how it has progressed. We've really expanded our horizons and therapeutic options in the last 10 years, which is fantastic news for patients. I think that where I'm going to be focusing on is on the right-hand side of the screen in terms of systemic treatments and their role in the management of HCC. So that is really where we talk about your first line being atezolizumab, bevacizumab, or durvalumab, tremelimumab. I hope I said those right. As first line therapy, with atezos-bev being the preferred option. These are, still very, very expensive, and we certainly aren't necessarily getting all patients on these treatments that require it, but they are starting to approve. Medical aids are starting to approve these therapies, and we are going to be dealing with patients who have successfully downstaged with them. In terms of your future therapies, there are a considerable number that are gradually coming up. As you can see, the list is growing, and I think they're getting more and more innovative with these names, just trying to make them harder and harder to pronounce. Tislelizumab, for instance, and it is an expanding field. So let's just quickly go through some of these therapies, starting with the good old sorafenib, which most individuals are aware of. Sorafenib being a multikinase inhibitor, blocking your vascular endothelial growth factors as well as BRAF, showing improved survival compared with placebo. Not all that much, as you can see, only really about 2 and a bit months, 10.7 versus 7.9 compared to placebo. This is really indicated for patients with well-preserved liver function who progress on local regional therapies. Right. In terms of lenvatinib and regorafenib, these are then your second-line agents. Also, multikinase inhibitors. Multikinase inhibitors targeting your vascular endothelial growth factors. As you can see, in terms of regorafenib being standard of care for patients with advanced HCC who have tolerated sorafenib but progressed with well-preserved liver function and ECOG performance status 0, which is a very select group of individuals. This has led to then the immunotherapy era, and really the big boy on the block is atezos and bev, and this is based on the IMbrave 150 trial. Atezolizumab selectively targets your PD-ligand 1 to prevent interaction with the receptors PD-1 and B7, thus reversing T-cell suppression, allowing the T-cell to then activate and attack the cancer cells. Bevacizumab then is a monoclonal antibody targeting vascular endothelial growth factor, inhibiting angiogenesis and tumor growth, showing response rates of 13 to 14% in patients with advanced liver cancer, and the combination of which being significantly better. Your IMbrave 150 inclusion criteria: eligible patients who had not received systemic therapy already, not amenable to curative or local regional therapies, or who had progressed thereafter, a performance status of 0 or 1 on the ECOG scale, Child-Pugh A, and adequate hematologic and organ function. Exclusion criteria were history of autoimmune disease, co-infected Hep B or Hep C, patients who had underwent organ transplantation, because of bevacizumab being a vascular growth factor inhibitor, untreated or incompletely treated esophageal or gastric varices with bleeding or high-risk stigmata, and then CNS, autoimmune CNS disease such as myasthenia or Guillain-Barré, and then obviously active TB. And this then showed significantly better results. It's still low. It's still a difficult to treat disease. So you are talking about progression-free survival of 6.8 months versus 4.3 months for sorafenib. But I think, don't be discouraged by those sort of numbers. The devil is in the detail, and you do get individuals that do respond that much more significantly to these sort of therapies. Further drugs, durvalumab and tremelimumab, were proven with the Himalaya trial. Durvalumab being PD-L1 and tremelimumab being an anti-CTLA-4 blocker. They looked at overall survival versus sorafenib, and looking at survival data, which was significantly better, and thus it is approved for treatment of HCC. Just remember that immunotherapy-wise, you have a variety of toxicities that are then immune-mediated. You have effectively a hyperactivation of the immune system, resulting in various autoimmune-like conditions. This, commonly checkpoint inhibitor hepatitis or immune therapy hepatitis, hyperphysitis in terms of various pituitary hormone abnormalities, be it hypo or hyperthyroidism or adrenal insufficiency. Checkpoint inhibitor colitis is also relatively common, and then various forms of dermatitis also being reported, but these can affect pretty much any one of these systems listed, and it is important to know how to manage them, as not all of them are managed in the same way. Your checkpoint inhibitor colitides, for instance, can be managed with certain other biologic drugs such as vedolizumab, for instance, but not so much your checkpoint hepatitis, which we treat with steroid and mycophenolate. So remember this slide then. We only managed to transplant 31 patients in sub-Saharan, in South Africa. And, it not really being an all that great a number. This comes to where we talk about transplantation for HCC then, and just in terms of what do we mean by bridging therapies and downstaging patients. So bridging therapies in hepatocellular carcinoma involve treating the patient that is already listed for transplantation and is within criteria. This is done in order to avoid them progressing as they wait on the list. You don't want this patient to be listed in June, and in October, when you call him up or her up for transplantation, you now find that the tumor is no longer within criteria. So it's a bridging therapy towards transplantation. Downstaging is the treatment of hepatocellular carcinoma that is already beyond criteria for orthotopic liver transplant, with an intent to reduce tumor volume or other aspects such as alpha-fetoprotein level to within accepted criteria. Whichever criteria you may be using, whether that be Milan criteria, UCSF criteria. There are a number of criterions, as I'm sure Sanju has already elucidated, but get the patient to within that group. So liver transplant in terms of downstaging is associated with good outcomes. It can be achieved in a good number of cases. Some reports suggest that even anything between 60 and 70% of cases can still be downstaged. It is also associated with durable long-term outcomes. This is a study looking at 10-year data from the US and published in JAMA in 2022. It's not necessarily the same as patients who have already presented within Milan criteria, for instance, that still have certainly the best outcome. It's clearly, as you can see, a somewhat in-between margin between patients that are beyond Milan criteria and did not receive downstaging and patients who received some form of downstaging therapy. Having better outcomes. And I think, looking at the first or the graph on top is survival, and the graph below is looking at recurrence, and you can see that there is certainly a significant gap between the two there. So, with all these various therapies, the European Society for Organ Transplantation put a consensus report on downstaging, bridging, and immunotherapy in liver transplantation for hepatocellular carcinoma, and it was published in September of last year. If anyone is interested, it's in Transplantation International, and the reference is below. So firstly, should all patients outside transplant criteria, all comers, be considered for downstaging? And the evidence there was that as long as they don't have any extrahepatic disease or macrovascular invasion, these patients should be considered for downstaging, as long as they are otherwise suitable in terms of performance status. And this is because the original HCC state has not demonstrated to significantly hamper post-transplant status. Sorry, my computer's just playing games with me. It's just screen's darkened slightly. Okay, it's stable now. So downstaging is a way of you proving what is the giving a trial of what's the tumor biology like. If a patient has a large tumor that you then taste and it responds very well, or the patient receives some form of immunotherapy and that tumor necroses, these are the patients that potentially have a better outcome as opposed to a patient who receives treatment and still has ongoing aggressive disease that you're obviously not going to be able to transplant. Immune therapy then for downstaging has long been considered contraindicated in transplant patients. There have been concerns about early graft loss in patients treated with immunotherapy, and that was highlighted when certain patients were transplanted, having come off therapy for a very short period. It looks like the magic number is that these patients should be treated and then be off treatment for a minimum of 4 weeks and ideally 6 weeks from their last dose of atezo-bev. Basically that immune hyperactivation essentially resulted in rapid rejection of these patients' grafts. Rejection can still occur, but has been shown that if you time it right, you can treat it in a standard fashion, and the graft survive quite relatively well. The IMbrave 050 trial then, so it's different to the IMbrave 150 trial. This then assessed the use of atezo-bev in the post-resection or ablation setting. Patients were selected with a high risk of recurrent disease. So this was where there was a high number, whether there was microvascular invasion on histology, whether there was lymphatic invasion, and it was shown to be efficacious and well tolerated in these patients. And where you have a downstaging into your criteria, it would then be possible to get to curative intent with these patients. So that's an exciting outcome. I think I've already kind of talked about this, but immunotherapy is slowly becoming the standard treatment for advanced unresectable HCC who are not amenable to local regional therapy. And because of the promising results, interest has been raised for the use of immunotherapy in a neoadjuvant setting. Where the exact, timing and stuff, as I said, is still concerning, but it looks like a minimum washout period of at least 4 weeks is and needs to be considered. So, looking at future therapies, I think a combination of various aspects is going to need to be considered in your patients. I think in the ideal world, because these are expensive modalities of therapy, if you look at TARE, it's about R500,000 per course of therapy. And if you want to then combine that with immune therapy, it is a very considerable rand price that you are paying for therapy, which is still at best considered a trial of therapy. If they respond, great. We still don't know who exactly is going to respond best to the various downstaging mechanisms. I think Sanju pointed out that some of his data is looking at that. But once we have better data on who will respond best, combination therapies can be considered with an intent to downstage all patients with HCC. So, getting back to that slide that where we said that despite such a high burden of HCC disease, we really only have transplanted such a few number. Resections are happening in such a low number. I think there's a lot of hope that in the future we'll be able to offer our patients with hepatocellular carcinoma better care. I think that is my last slide. I'll open for questions. So Dominic, I hope I answered your question. I think Prof. Sundarup, I think I saw you on a little earlier. I'm not sure if you're still on, if you care to comment.
It's not here anymore, Bilal.
Ah, okay. Zamo?
Hi, Bilal. Yeah, man.
Hey,
Nice chat. I just wanted to ask a quick one. Is there access to atezo-bev in South Africa? The last I checked, not, or there is now access.
So
because
it's not that easy.
Yeah.
And there are considerable hurdles that our medical oncology colleagues have to jump through. Interestingly, there is currently a trial with atezo. Let me just see which one it was now. I think it was atezo, bev, and was it tremelimumab as like a triple therapy that is currently available, that we're trying to get patients onto at the moment, and there are a few that have done so. So yes, we are getting patients on, and the hope is that these can be downstaged.
Yeah.
What about your guys' experience at King's?
It's definitely a very interesting space. So we sure using it as first line for systemic therapy. And then there is also some stuff for adjuvant therapy post-curative treatment, whether it's transplant or resection. And that work is now obviously currently underway. Whether or not that will, I think this IMBRAVE 050 shows decrease or improved recurrence-free survival, but not necessarily overall survival at this stage. So that's just something that we're looking at as well. I think what was interesting is that we did have one patient who was transplanted who was, I think, initially rejected or outside of criteria at one of the other centers, was on systemic therapy, so was on atezo-bev, and then referred for second opinion. And I think we ended up transplanting said individual, and they actually are doing well. I think about a year now post-transplantation. But that's
how long did you wait in terms of your washout?
I can't remember the exact details per se, but yeah, I think it was on that line of 4 weeks, 4 to 8 weeks. Obviously, issues with wound healing and bleeding, etc. So yeah, so that's that was just that one experience that we had with pre-transplant or neoadjuvant immunotherapy. But the other thing that I wanted to just ask or just clarify was the role of ablative therapy. I know that Sanju, I wanted to ask him, the review showed that very, very few people actually had ablative therapy, and that's one of the, let me say, modalities that we use here quite a lot, particularly those patients that are screened or screen detected or surveillance detected lesions that are early stage. So, your microwave ablation, radiofrequency ablation, etc. Very, very, there's a high proportion. So I would obviously assume that maybe that's not an option in our context back home because patients are possibly presenting a little bit later, or, BCLC-B or C.
Mzamo, I think I think the patients who are under surveillance, and there's obviously a category of these patients. If the lesion is small, 2 centimeters or less, and it's not very close to a portal vein radical, or there's no biliary sepsis in the patient, I think you should go ahead and offer them microwave or radiofrequency ablation. Interestingly, in our experience, I mean, I think Prof. Spearman and Prof. Sondrop is not here anymore in the forum, but what we found was super useful in our setup is an all-trick alcohol injection. And in fact, in small lesions, in cirrhotic patients, it was very well tolerated by the patients. 1 or 2 had a bit of hepatic decompensation, but recovered. And the argument we made is that if there's something you want to promote in sub-Saharan Africa that's easy to do, relatively, with an ultrasound and a lesion that's not too deep nor too shallow, I think it's a very good modality to use. And the other thing I want to say is if you have 3 lesions and they are all amenable to ablation, then it's not a bad idea to ablate them, considering the fact that the cirrhotic ones, what's the other option? You transplant them or you TACE, which is difficult to get in our setup. You can't really resect them unless they're really, early Bs or late As. So it is a challenging situation. What I would say is if you have alcohol ablation, if you read the literature actually, you look at cases and so on in sub-Saharan Africa, a lot of centers still do alcohol ablation, and it's generally done by the surgeon or the hepatologist or some form of physician at that institution. Yeah, I think the other thing that it's stuff that keeps me awake at night, I thought about is I just don't know what these biologics will do for the non-cirrhotic patients in our setup. And if you look at most of the HCCs where this data comes from, it's for cirrhotic disease. It is. So 80% is cirrhotic disease. So these are all cirrhotic HCCs. I'm really not sure what it means for our patients with these non-cirrhotic tumors. I mean, we have shown already that their biology is completely different. They produce
absolutely.
a lot of hydroxybutyrate. They're hotter tumors. I don't have an answer for that. I mean, it'd be interesting to see in the limb in our trial for the patients who are getting these biologics in Johannesburg at the moment, because they all need to be biopsied. So some of them you'll be able to show for sure whether that's cirrhosis or not, or their scans are quite convincing. It'd be interesting to see what it does.
Yeah, absolutely. I think definitely when it comes to that small subgroup of non-cirrhotic HCCs, whether it be the measles or the hepatitis B, that's something I don't think has been looked at quite carefully here either. And now we're going back to kind of look at these a little bit closer. So I think certainly if you are biopsying all the patients, before treatment, that's going to be very useful. And because a lot of
the other interesting thing, sorry to disrupt, but the other interesting thing we found, which also baffled us when we looked at our large cohort, is that we are seeing more patients with non-cirrhotic HCC, even in the non-Hep B group. And you can see these patients are more lipemic, they have more metabolic dysfunction, they are diabetic, they have high cholesterol. We are seeing more non-cirrhotic patients in there. And if you look at the Indian experience, they'll tell you 1 in 3 people have NASH in India, or MAFLD, or MASLD, or whatever you call it these days. And most of the tumors they see in these people, young people, are non-cirrhotic. So it's a very interesting concept. But I think we will have some answers, I think, from our group in the next 3 months as to what non-cirrhotic HCC means at a single cell level, because we have 4 non-cirrhotic and 4 cirrhotic ones, matched age and sex, all Hep B. It'll be interesting to see what we find in these tumors.
Yeah, definitely. We're keen to see that data.
So Mzamu, I think the big question in terms of what to do with these small lesions that would be amenable to ablative therapies. The problem is that it's we don't have adequate screening programs. We don't have adequate ultrasound surveillance picking these up when they're small. The majority of HCC in sub-Saharan Africa are presenting when they're already large and symptomatic, and therefore very little can actually be done. And I think that's more of a problem. I think your simple, elegant alcohol or even cryoablation, microwave ablation, cheap oldish technologies are really for individuals that are in those regular 6-monthly surveillance programs where they're asymptomatic and being picked up, as opposed to the late stage that we're often seeing that then requires downstaging. Dominic's also asked, what has your experience been in Johannesburg regarding bridging patients outside? So I think regarding downstaging for patients outside transplant criteria, remember that bridging is you are within transplant criteria and want to keep them in place, whereas downstaging is when they're out of criteria and then regress back in. And look, I think we have certainly had some successes. There's a gentleman that's still running around now was a Hep C cirrhosis with portal vein involvement that received transarterial radiation embolization tear. He's, like I say, he's doing amazingly well 8 years out, and on his explant we couldn't really see much HCC, viable HCC. There've been I think he's the poster boy because he just had such a dramatic response. But at the same time, there've been others who have not had as dramatic an improvement. Not sure if there's any further.
Hi, Bilal.
I know.
So just a comment with regards to our patients who often present quite late, that we have tried to get on the clinical trial. I think we're also doing the atezo-bev trial, but quite a few of them have failed, because I remember one of them had co-infection with Hep B, Hep C, I think, if I'm not mistaken. And also, one also had concomitant AIH, which I wasn't aware is an exclusion criteria. So it's been extremely frustrating because we've not been able to get these patients onto this this clinical trial. And as you know, I mean, in terms of local regional therapy, there's not much that we'll be able to offer them, but we'll be discussing with our radiologist tomorrow to see how we can improve access to some form of local regional therapies for our patients. But in terms of clinical trials, oncology, whatnot, nothing. So it's usually just diagnosis and then palliative care.
Yeah. Yeah, I think with our sub-Saharan cohort, it is going to be difficult getting those patients without active Hep B, C, and then we've got a high burden of autoimmune liver disease as well.
I think TACE should become the the modality of choice for a lot of these patients. I mean, we've tasted 150 patients at Good as Care, and at one point we were probably doing the most TACE in the world. That was about 4 months ago before I left, for us, when we look at we're analyzing the results now, I think we get phenomenal results out of it. And I'm going to share this now, but the manuscript is in preparation. If you compare sorafenib TACE and best supportive care in a matched cohort, the patients who have TACE survive 3 times longer. And the cost of doxorubicin at this point is 800 rands a dose. So it is an interesting avenue. I think a lot of us do look at the lesions and say, it's not tasteable or it's impossible. I mean, we've tasted in the face of hepatic vein thrombosis. We've tasted in patients with distal portal vein tumor thrombus. We've been quite ruthless about it. We've learned, in the beginning, we learned through some major challenges. We lost patients. I'll say that particularly the ones with lung mets, high gamma GT, high hydroxybutyrate. But I think TACE in a patient that's relatively well, where you can't offer them a biologic or they can't get into a trial, is definitely a very good downstaging modality. We have patients who came in with AFPs of 200,000. We taste them, repeat a scan at 6 weeks, and we do the AFP and it's down to 8. And we don't know why. We think that these tumors in our setup have a lot of glutathione in the livers, particularly in our population, and that makes them very sensitive to the doxorubicin. So I would say if we can offer that, certainly I think that's a very interesting modality of care.
I think it is 5:30.
Yep.
So time to close the meeting. Who is our chair?
I mean, you can be the chair now. I opened.
Okay.
Now. Okay.
All right. So I'd like to thank the presenters, Sanju, me, right, for putting together today's meeting, as well as Karen Fenton, Cheryl Valentine from the ECHO team in Cape Town, as well as not forgetting the ECHO India and ECHO New Mexico team that make these meetings possible. Special thanks to the sponsors that enable us to have these meetings every Wednesday. And please join in for next week's session. I am not certain what next week's session is, but there will be a gastro echo session next week, Wednesday at the same time. So please tune in. Thank you very much, everybody.
Thanks, everybody.